Okay, so pneumonia. So pneumonia is common, right? And it can make people really sick. So you can have different degrees of pneumonia. You might have a mild small pneumonia in one lobe of your lung, or you may have bilateral pneumonia in multiple areas of both lungs. Okay, so pneumonia is infection, typically viral or bacterial, that is filling the alveoli with fluid and infection, causing a lot of inflammation. So what kind of problem is this? Well, it's going to end up being a diffusion problem, right? Because as the alveoli fill with fluid and pus, well, oxygen can't get there anymore. So the body's going to have problems oxygenating the blood, okay, because it's losing a segment um, of the lung to infection, right? And on top of that, when your lung is filled with bacteria and fluid and pus, it's gonna be not only be hard to perform diffusion, and that's why you're going to be hypoxemic, but it's going to also start to affect ventilation because it's hard to expand stiff area of the lung because it's filled with fluid. Okay, so it can affect diffusion, and as it gets larger and larger, it can actually affect ventilation because it's causing a stiff lung. So what are the symptoms? Well, sure, you could have some anxiety, you could have fatigue and weakness, which could go along with really with any illness. I mean, anxiety because you're short of breath, really. Chest discomfort because you're coughing so much. So let's think of the common symptoms: fever, shortness of breath, coughing, purulent phlegm production. So if they're coughing up phlegm, it's usually purulent in color. Okay, kind of um, uh, greenish phlegm. Okay, um, they can be confused. Why? Because they may be hypoxemic. Okay, and if you're hypoxemic, you don't get enough oxygen to your brain. You can get confused or agitated. Okay, so the the physical assessment findings, well, fevers and chills from the infection, sure. Flushed face from the fever, diaphoresis is sweating, shortness of breath, which is the same as dyspnea because there's a part of your lung that the body's having difficulty expanding, so the sensation of shortness of breath. Tachypnea, you're breathing faster to try and get rid of the CO2 and maintain oxygenation of the blood because there's a segment that's infected and filled with fluid. Okay. Tachypnea is breathing fast, sure. Okay. Pleuritic chest pain if the pneumonia is touching the pleura. So every time you take a deep breath, oh, it hurts because it's inflamed the pleura. The yellow-green sputum production. When we listen to the chest, focal coarse crackles. So if it's a left lower pneumonia, when we listen to the left lower area, there'll be coarse crackles and crepitations. It sounds like Rice Krispies when you put milk on them. Okay, and of course lots of coughing. Now you can have purulent blood tinged sputum, someone who's coughing up kind of this um, uh, greenish yellow phlegm. It can be blood tinged with pneumonia. The area when you tap over it is dull to percussion because pneumonia is liquid and it's not air anymore, so it's not resonant. It's becoming dull to percussion. Okay. Okay, so diagnostics for pneumonia. So lab tests. If we're lucky, we can get a sputum culture. So if someone's really hacking up phlegm, not saliva, we don't send off saliva because it's not useful. But if they're able to give us a really good sputum sample, we'll send it for a culture and sensitivity that we'll get back 2 or 3 days later. And we'll typically try and do that before giving any antibiotics. Remember, we try and take samples for culturing before ever giving antibiotics, if possible. A chest x-ray, very useful for looking at pneumonia. Okay, chest x-rays can definitely pick up pneumonia. As you can see in this image, there's a right upper lobe pneumonia, and you can see how it's opacified, it's all white, and it's because the x-rays aren't going through it, because there's fluid and pus and infection there. Okay. Other blood work. Sorry, I went off topic in terms of the chest x-ray. Let me come back. A CBC often will see an elevated white blood cell count. If it's a bacterial pneumonia, typically the neutrophils have a higher percentage of the white blood cell count. If it's a viral pneumonia, typically we'll see an elevation of the lymphocytes as the predominant elevated part of the white blood cell count. Okay. Arterial blood gases can be useful because, remember, this person may not be oxygenating their blood very well. And we're going to pick up a low O2 sat on pulse oximetry. And on arterial blood gases, we might see a low PaO2. We may see, again, a low O2 sat on the arterial blood gas. And if they're getting really sick, they're going to start retaining their CO2 because they can't clear it, because some of their alveoli are filled with pus and fluid. And we're going to see, if they start to retain CO2, we're going to start to see a drop in their pH. They're going to become acidotic, respiratory acidosis. Okay. Often we'll take blood cultures, especially if someone's complaining of fevers and chills and rigors. We'll take blood cultures. All of this is before antibiotics. I mentioned chest x-ray and I mentioned pulse oximetry. Sometimes even with a large pneumonia, on top of the chest x-ray, we'll do a CAT scan to see the extent of the pneumonia in the chest. Not always, but with a very extensive pneumonia, we may do a chest x-ray. A CAT scan. Okay, so let's just talk about someone who's lying in bed with pneumonia. Okay, so they may need oxygen because they're hypoxemic. Okay, so if there's enough of their lung involved, they may need administration of oxygen, whether it's in nasal prongs or a facial mask. It just depends on, when we look at the O2 sat monitor, how it's improved by the administration of oxygen. Okay. We typically have patients sitting upright if they're able to, right? When you sit upright, your diaphragm goes down and you're able to take better breaths. So most patients with pneumonia are not lying flat in bed because they're too short of breath. Okay? We encourage patients to cough and get all that phlegm out. Older people have difficulty getting those secretions and phlegm, and you can hear it just rattling in their chest. And that is unfortunately not a good sign because it means they're unable to clear the secretions. Okay. While in bed, they may run into problems with bed ulcers. You often start to get skin breakdown around where you're receiving oxygen, right? Dry mouth, dry nose from the oxygen. We can encourage them to use an incentive spirometer to prevent atelectasis. So if they have a pneumonia, you don't want more collapse of other parts of the lungs called atelectasis. So an incentive spirometer to make sure that they're keeping all the alveoli as open as possible. Okay. Making sure that they're getting proper nutrition and they're drinking well to avoid getting dehydrated. Okay, so whenever you have an infection, you're actually using more energy to try and fight the infection. So maintaining proper nutrition, making sure that you're drinking well, which is typically 2 to 3 liters a day. And rest periods for patients who have pneumonia so that their body can fight the infection. Okay. So what else? Suctioning is definitely important. A patient can sometimes get some of the secretions up to a certain level, and suctioning can help remove that. Now, eye cough. So those bullet points under eye cough there: incentive spirometer, coughing and deep breathing, oral care, getting out of bed 3 times a day. head of the bed elevation, those really sound like objectives of avoiding pneumonia, especially post-operatively. Okay, so the incentive spirometer is to make sure you don't get atelectasis. The coughing and deep breathing, same idea. Oral care, making sure that you don't aspirate bacteria from the mouth into the lungs. Getting out of bed, well, when you get out of bed, you're moving, your diaphragm's going down because of gravity, taking nice breaths. And that's what head of the bed elevation does, right? Making sure that you're getting nice breaths into the lungs, which prevent pneumonia. Now, in terms of medications, we're going to talk about those a bit more. Antibiotics, for sure, because I mentioned you can't tell if it's bacterial or viral pneumonia. Yes, we take sputum cultures, we take blood cultures, but they don't always come back positive, so we always treat pneumonia with antibiotics. What else can we use? Well, if someone has a lot of mucus in their airways, we can use bronchodilators. So sometimes we'll give people albuterol, which is a short-acting beta agonist, to just try and bronchodilate to get the oxygen down to their lungs. Cholinergic antagonists, I mentioned, they're bronchodilators as well, such as ipratropium. Methylxanthines, again, bronchodilators, that's theophylline. Again, theophylline, I mentioned, has a lot of side effects, a lot of drug interactions, and on top of that, you have to monitor blood levels. Okay, so a bit of a painful drug to administer and to take. Okay, now anti-inflammatories. Some patients with pneumonia, there's so much inflammation that we're going to use an anti-inflammatory, such as an inhaler, fluticasone. Often we'll use an oral glucocorticoid, such as prednisone, okay, to treat all the inflammation that's occurring in the lungs. Okay, make sure you know your side effects of glucocorticoids for any condition that they're being used for, right? So glucocorticoids, they reduce immunity. So in actual fact, you're more at risk for infections if you're on long-term glucocorticoids. They're going to stimulate release of sugar or glucose from the liver. You're going to develop hyperglycemia. They retain fluid from the kidneys, so peripheral edema, weight gain. You get much more of an appetite as well when you're on glucocorticoids. So that's going to be another factor of gaining weight. Okay, they can thin the patient's skin significantly. Okay, so bruising and torn skin can happen. Thrush in the mouth can develop, and actually aphthous ulcers that we call canker sores, they can also develop. But thrush in the mouth from immunosuppression with glucocorticoids can definitely happen. They can lead to peptic ulcer disease. Why? They're really hard on the stomach, and they thin the stomach lining, which can lead to peptic ulcer disease, causing black tarry stools. That's melena. Okay. We always advise patients to take oral glucocorticoids with food. Okay, so if someone's taking prednisone, it needs to be with food because it irritates the stomach. And we also tell patients taking glucocorticoids, if you're taking them for more than 2.5, 3 weeks, you need to taper them. And that takes some advice in terms of tapering them. If it's just a short burst of a glucocorticoid, say 5 or 7 days, there's no need to taper. Okay. Okay, so I find myself saying information on the slide before. I don't do it on purpose, it's just that it comes to my mind and I thought, oh, I better mention this. Okay, so treatments for pneumonia, we've covered this slide. Let's go into a couple of antibiotics. So penicillins and cousins of penicillins called cephalosporins are very common antibiotics for pneumonia. Okay. Remember, if you have a severe penicillin allergy, we don't give cephalosporins. If you have a mild penicillin allergy, such as a rash, then we do use cephalosporins because They're a cousin of penicillins, and with mild allergies, mild penicillin allergies, we can still use them. Okay. With antibiotic that we're administering, whether it's penicillin or a macrolide such as azithromycin or erythromycin, we get the cultures before. If we're going to take cultures, we get them before the antibiotic. Okay. The bronchodilators I mentioned, a beta-2 agonist such as albuterol, or a cholinergic antagonist such as ipratropium, just to open the airways a bit. And when we're talking about anti-inflammatories for pneumonia, it's going to be glucocorticoids. If they have a mild pneumonia, we could use fluticasone, which is an inhaled version. If they have a more severe pneumonia, we could use oral prednisone or methylprednisolone, which is IV. It doesn't really make much sense to give a drug that has immunosuppressive effects to someone who has an infection, but they tend to clear up the inflammation really well. So that's why we use them for short-term treatment of pneumonia. They don't stay on this for months and months, right? So it's for short-term treatment of the inflammation. Okay, so for patient education for pneumonia, remember, many patients with pneumonia end up going home. They don't necessarily get admitted to hospital, right? But someone who has pneumonia has low O2 saturations, or they're weak, sick, short of breath, then we'll admit them. Or if they're dehydrated. Or when we look at them, we notice you look quite short of breath, you're working hard to breathe, you're requiring a bit of oxygen in the emergency room. Okay, you need to stay with us for treatment. Okay, so, but there's a good percentage of people that go home with antibiotics, sometimes a bronchodilator such as albuterol, and a short course of, say, prednisone. Okay. What else is important? So I mentioned the medications, the maintaining a good hydration with fluids and good nutrition to fight the infection. Spoke about ICOF, that acronym. Rest periods is important because you only have so much energy for a given day. So, if you have pneumonia, you want some of your energy to be diverted to fighting the infection. Okay. Proper hand hygiene to avoid spreading it, whether it's the patient or the staff that's caring for the patient. And recovery takes time, and it also depends on the patient. So someone who's very old and frail, it's going to take much longer to get back to their baseline compared to a 30-year-old with pneumonia. There's pneumonia vaccines, so Pneumovax, to try and prevent at-risk patients from developing pneumonia or recurrent pneumonia. And of course, advising smoking cessation, right? So smoking is a risk factor for developing recurrent pneumonia, right? It's irritating the bronchial tubes, it's damaging the alveoli, and it puts people at risk for developing pneumonia. They can't clear their phlegm as well. The little cilia in all the bronchial tubes don't move as well, so they're more at risk for developing a pneumonia. So what are complications of pneumonia? Well, if the pneumonia is significant and it's a large portion of the lung or a lobe of the lung, well, the patient will become hypoxemic. They may have difficulty taking breaths. Their work of breathing might be significant and they may tire out and they would need to be intubated and ventilated. Okay. So we monitor patients with pneumonia for increasing respiratory distress, decreasing oxygen saturation levels, and that's usually an indication that they're starting to tire from the pneumonia, and they may end up on a ventilator. Okay. So another complication, atelectasis. So atelectasis just means other parts of the lung are collapsing because you're not taking good breaths from the pneumonia to begin with. Okay, and that's going to lead to more hypoxemia. Okay, and that's one of the reasons why we can encourage using an incentive spirometer to maintain or to avoid alveolar collapse in other parts of the lung. Bacteremia means that the bacteria from the pneumonia is now leaking into the bloodstream, and bacteremia leads to sepsis, right? Which is an inflammatory condition in the system, in your bloodstream, and of course all your organs, causing tachycardia, hypotension, confusion. Just depends on which organ you want to talk about. If it's the brain, confusion, agitation. If it's the kidneys, renal failure due to hypotension and all the inflammatory molecules that are blocking up the kidney. So sepsis is definitely a complication of pneumonia, and it's a bad complication. Acute respiratory distress syndrome can be from any severe illness, including pneumonia. So what happens is the pneumonia causes diffuse vasodilation of the blood vessels in the lung, and you get, when you have fluid all throughout your lungs, you get stiff lungs. They don't expand well, so they have reduced capacity, right? And you get more and more short of breath because now there's fluid throughout both lungs. Okay, and often these patients will end up needing a ventilator because they have reduced O2 saturations and elevated CO2 levels in the blood. Okay, so let's do the questions at the back of chapter 20. Okay, so a nurse is monitoring a group of clients for increased risk for developing pneumonia. Which of the following clients should the nurse expect to be at risk? Okay, so let's just talk about briefly the risk factors for developing pneumonia. So very, very young people, so infants and neonates, and old people are at risk for developing pneumonia. Both extremes have poorly developed immune systems if they're young, and they have declining immune systems if they're old. Patients that have been exposed to a viral or bacterial infection, they're at higher risk for developing pneumonia. Lack of immunizations, so they didn't receive their pneumovax or their influenza vaccine. Smoking leads to COPD. COPD is a risk factor for developing recurrent pneumonias. Okay, so on top of having the COPD, you're developing recurrent pneumonias. Okay, not good. Alcoholism is a risk factor. So alcohol actually suppresses the immune system, and alcoholics are at risk for aspirating because they're sometimes semi-conscious or unconscious. Chronic lung disease, I mentioned. So COPD would be the main chronic lung disease that would lead to recurrent pneumonia. Anyone who's immunocompromised for any reason, whether it's from a disease they have or treatment they're receiving, such as glucocorticoids or immunosuppressants. The presence of a foreign body in your lung, say you aspirated something or you choked on something and it went into your bronchial tube. Well, that's a perfect place to develop a pneumonia, so a foreign body. So typically we have to go and retrieve foreign bodies. Okay? Any condition that puts you at risk for aspiration, difficulty swallowing after a stroke, decreased level of consciousness after a stroke or a head injury would be a risk factor for aspirating. Okay? Poor mobility. So you're immobile from a bilateral femur fracture and you're lying in bed. I mentioned decreased level of consciousness would be a risk factor for aspirating. On a mechanical ventilator, definitely a risk factor for developing a pneumonia. Okay, so let's look at the answers. A client who has dysphagia, so that's difficulty and discomfort with swallowing, yes, that would be a risk factor for aspirating. A client who has AIDS, well, they're immunosuppressed if you have AIDS, right? AIDS means that not only are you HIV positive, but you're at a point in the disease of having a human immunodeficiency virus that you have AIDS, and that's at a CD4 count, usually at 200, and you're at serious risk of developing pneumonia. A client who was vaccinated with pneumococcus and influenza 6 months ago, that wouldn't be a risk factor, that would be a good thing. A client who is post-operative and has received local anesthesia, no, that's not a risk factor if they received local anesthesia. If they had general anesthesia and they were unconscious, that would be a risk factor because they would have potentially required being intubated. But a local anesthetic is not a risk factor for developing pneumonia. A client who has a closed head injury and is receiving mechanical ventilation, definitely, right? So they have a foreign object down, they have an endotracheal tube in their lungs, and there's a machine breathing for them. Definitely a risk factor for pneumonia. Client who has myasthenia gravis, absolutely. Myasthenia gravis is a condition of the synaptic cleft. So you have reduced acetylcholine at the neuromuscular junction. So you're going to have ventilation issues. You're not taking good breaths, right? Because the neuromuscular junction at the intercostal muscles and the diaphragm aren't expanding your lungs properly. So you'll develop atelectasis and pneumonia. So the answer A, B, E, and F. Number 2, a nurse is caring for a client who, upon awakening, was disoriented to person, place, and time. The client reports chills and chest pain that is worse upon inspiration. Which of the following actions is the nursing priority? Okay, so they're confused, and on top of that, they have chills and chest pain. So chills makes me think of infection. Chest pain makes me think of an infection in the lungs, and the confusion makes me think of they're low on oxygen. Okay, so what's the first answer? A, obtain baseline vital signs and oxygen saturation. Absolutely, number 1. They could be hypotensive, and that could be making them confused. Their oxygen could be low, and that could be making them confused. So you need vital signs and O2 sat. Obtain a sputum sample. That's not a priority at all. Obtain a complete history from the client. That's not going to happen because they're disoriented. And that's not a priority. Vital signs are a priority. Provide a pneumococcal vaccine. Not a priority. It'll take weeks to work, and need the vital signs and O2 sat first in this person. Okay, they don't sound well. Okay, so the answer is A. Number 3, nurse is caring for a client who has pneumonia. Assessment findings include temperature of 37.8, so low-grade fever, respirations of 30, that's on the high side. Typically we like to see respirations 12 to 16, 12 to 18. So 30 is high, they're breathing fast. Blood pressure 130 on 76, that's fine. Heart rate is high normal, 100. O2 sat is on the low side, 91%. They should be 95% or greater normally. Prioritize the following nursing interventions. Okay, so let's look at the interventions. Administer antibiotics, administer oxygen, perform a sputum culture, instruct the client to obtain a yearly influenza vaccine. Okay, so what's the first thing that needs to be done? Well, there are O2 sats on the low side. So we always have to think of ABCs, airway, breathing, and circulation. So it'd be nice to see that oxygen come up a bit and by providing oxygen therapy, because it'll come up quickly, typically with oxygen therapy. So B would be the first intervention. A would definitely be the second, right? So administering antibiotics early has been shown to have a better outcome for the patient as opposed to delayed antibiotics in pneumonia. Okay, so oxygen first, sure, we'd want to get the antibiotics in second as for these choices. And then we can get a sputum culture after, no, sorry, I didn't see that one. It should be B, administer oxygen therapy, get the sputum culture. Sorry, I didn't see that answer there. And then give the antibiotics. It doesn't take long to get a sputum culture, and we always get them before the antibiotics. And then the annual influenza vaccine can be discussed at a later point. Okay. Number 4, a nurse in a clinic is assessing a client who has sinusitis. Which of the following techniques should the nurse use to identify manifestations of this disorder? Percussion of the lower lobes of the lungs. Well, sinusitis is of the face, right? So that's not going to be the answer. Those sinuses are in the face, right? The frontal sinus, the maxillary sinus, and the ethmoid sinuses are deep behind the nose. Auscultation of the trachea. No, that's not where the sinuses are. That's not going to help. Inspection of the conjunctiva. No. The conjunctiva is the lining of the white part of your eye, or above the white part of your eye. So that could be involved in conjunctivitis, but that's not part of sinuses. Palpation of the orbital area. So if we palpate the orbital area, so above the eye, or even below the eye, we could be looking for a frontal sinusitis or a maxillary sinusitis. Okay, so the answer would be D here. 5. A nurse is teaching a group of clients about influenza. Which of the following client statements indicates an understanding of the teaching? I should wash my hands after blowing my nose to prevent spreading the disease. Absolutely. Yep, proper hand washing. I need to avoid drinking fluids if I develop symptoms. Not true. You should be drinking a good amount of fluids with influenza to avoid getting dehydrated. I need a flu shot every 2 years. No, it's annual. I should cover my mouth with my hand when I sneeze. Not really. It's probably better to use your elbow as opposed to your hands, because then you have to just recurrently wash your hands. So coughing into your elbow, avoiding to cough into your hands. Okay, good.